Hello, this is Lieutenant George Clevenger, student physical therapist with the Army Baylor Doctor of Physical Therapy program, intern at Texas Physical Therapy Specialist, Selma. It's a case study for 23 September 2011. Patient is a 40-year-old female, non-smoker, not pregnant. She's an event planner. She usually walks daily, 2 to 3 miles per day. Injury was insidious onset and surgery. Negative coughing, sneezing, saddle paresthesia, bowel or bladder. She does have numbness and tingling. That's P2. P1 is a constant variable soreness, 8 to 10 out of 10. Aggravating factors are walking, standing, sitting, and anything greater than 5 minutes. Easing is foot massage or manual pressure. P2 is a constant numbness in the heels. Aggravating factors, she feels it's worse when she puts pressure through her heels. It's immediately worse. And it gets a little better when she takes pressure off her feet. Things that make it better are application of manual pressure. Worse is sitting, standing, and walking. It's best in the morning before getting out of bed, but it's excruciating when she steps out of bed in the morning or after any sort of rest period. Again, she said it is worse at the end of the day. Aggravating factors are walking, standing, and sitting. See the ratings on the right. She has no past surgical history prior to this event. She takes a leave to decrease her pain. There's no MRIs or x-rays. A photo score, she's higher than the mean. She does have a moderate fear score. Predicted change is 19 over 14 visits. Her current pain is a plantar surface heel and plantar surface and heel of her foot. Her gradual pain, she had increasing heel pain since 2009. And on June 2010, she had bilateral plantar fasciectomy. And symptoms for both continue to get worse. She has received treatment. Well, treatment for the gradual was the plantar fasciectomy, and it has not getting better. She's having moderate difficulty sleeping. Her personal goals are return to walking and perform her daily activities without increasing pain. No remarkable medical history. Her current experiencing numbness and tingling, which is P2. Primary hypothesis is pain from post-op complications. Secondary, or P2, tibialis posterior referral pain. Competing hypothesis, they only have one for P1. It's the incision site is one of the primary tender points, and plantar surface of her foot. P2, competing hypothesis would be a neurotension. Objective: defer the neurospine screen. The standing increased her pain to 8 to 9 out of 10. She reported that once that pain is onset, 8 to 9 out of 10, it stays around for greater than 2 hours. The hip and knee were within normal limits. All range of motions with overpressures were unremarkable. Ankle motion was limited bilateral, hypomobile with long axis traction and anterior posterior glides. She was tender to palpation on the plantar and dorsal aspects of her feet. Incision site was very tender to palpation. Light touch resulted in a foot jerk-like response. The tibialis posterior was non-tender to palpation. The incision was clean, dry, well healed. It had some slight restriction with mobility of the scar. With manual muscle testing, all 5 out of 5 bilateral, although resisted tibialis anterior did increase the dorsal symptoms on the right. You see the active range of motions below, before and after HVT. Plantar flexion didn't change statistically or clinically. Dorsiflexion did. A neuroscreen, basically a neuroscreen was within normal limits, although there was a decreased sensation to light touch on the medial aspect and heel of left foot. It was a non-dermatomal pattern and non-peripheral nerve pattern. Special test. Neurotension sciatic nerve was negative. Slump test was negative. Windlast was negative for reproducing plantar fascial pain. She actually reported that it felt good. Goes along with she doesn't have a plantar fascia anymore. Hypothesis confirmed. P1, tender palpation of plantar surface. The incision site was very tender palpation. And for P2, we had the tibialis posterior was non-tender palpation, could not reproduce any of her symptoms. Slump test was negative. Sciatic nerve was negative, so was not able to rule in or rule out a P2. Thorax the same day. Gave her gastroc soleus and windlass stretching. That's all we did day one. Manual therapy, did Taylor Cruel distraction, traction manip, did Taylor Cruel AP glides with physiological dorsiflexion. Retested her dorsiflexion and plantar flexion at the end of the day. As you can see from the previous graphs, the dorsiflexion improved 7 on the left and 4 on the right. Plantar flexion didn't show much improvement past the NCID of the Goni. HEP was the same as our same-day Therax. We also directed patient to start soft tissue massage of the incision site. Educated patient on proper gait mechanics and had her concentrate on heel-to-toe walking instead of the shuffling she presented with when she walked in. On the first follow-up visit, asked her 5 Qs. The patient reported feeling much better after the last visit. Her ankles feeling loose for about 2 days, and the 3rd day she felt it stiffen up again. She performed simple country line dancing on the 2nd night after her initial visit, which was very encouraging. And now she feels very stiff. Her dorsiflexion left and right, although not back to day 1, did decrease from last visit. The patient reports being compliant with her HEP. Treatment 2, same as the first day. We added the 4-way ankle T-bands, towel scrunches, and short foot arc. Manual, same as day 1. We also added soft tissue mobilizations. Tried A-stem, but she was a little too sensitive for A-stem, so it resulted in immediate withdrawal, foot withdrawal reflex when I applied the tools. We'll reassess that next visit. Post-treatment, we had full passive range of motion in the ankle with increased pain on the dorsal surface of the foot at end range dorsiflexion. HEP, we added the towel scrunches and the short foot arc. Plan was to continue on this plan of care. We're going to concentrate on manual therapy and the foot intrinsic strengthening. 3rd visit, she reported she was sore after the last visit and lasted for 1 to 2 hours. She reported it was related primarily to the soft tissue area or the incision side of the scar. She reports feeling okay today, although her ankles do feel stiff. Dorsiflexion. Both dorsiflexion were not as great as when a post-treatment last visit, but left was greater than pre-treatment last visit. HEP reports again being compliant. Treatment the same as previous visit, both manual and Therax. Ranges of motion again are right on the edge of normal active range of motion, so the range of motion is increasing. HEP, we kept that the same. And continue with the POC with manual therapy and intrinsics. Next visit, plan to progress your proprioceptive exercises. On the fourth visit, patient reports the incision site and the dorsal aspect of her foot, left greater than right, were sore after last visit, and this time it lasted 1 to 2 hours. But then it's also been a week since the last visit, since she was very busy since the last visit. Today she feels it very stiff, like it needs to pop. Dorsiflexion, left and right, were similar to that of when she last entered the clinic. She was mildly compliant with her HEP, Being busy, she said she performed some of the exercises, but not all the exercises, and did not do soft tissue massage or soft tissue mobilization. Treatment for 4 had some of the same exercises as previous treatment. We added the BAPS board for 2 minutes, some marble transfers, and single leg stance 3 times 30 seconds. Manual therapy, continuing along the same path. This time with the soft tissue massage, started out with using a manual massage with fingers and worked into the iStem using the tools. She was still a little tender, but she tolerated it. Post-treatment, left dorsiflexion we're not able to achieve the same as previous. Right dorsiflexion again is borderline normal. The patient is now experiencing pain similar to that of pre-surgery. She said the symptoms are the same as she had prior to surgery, just they're actually now worse than before surgery. The pain is a 6 out of 10. The dorsal lateral surface of both feet, but left greater than right. It's at the approximate location of the ATFL. Patient denies tripping or spraining her ankles anytime recently. And a negative talar tilt, although there was some moderate pain with inversion. Eversion actually resulted in the greatest amount of increase in pain. Negative anterior drawer, negative internal or external rotation. Did have pain that increased the plantar and dorsal lobes of the cuboid. Also had increased pain with pressure under the navicular, but not with navicular lobes. It was when pressure on the soft tissue underneath the navicular. Her other symptom is she presents with this horseshoe-like pain around the calcaneus on the lateral side of feet, more the medial, and again this is bilateral. No pain was reproduced. Either one of these pains were reproduced with resisted motions in the leg, because the lateral aspect pain again was more prominent. I checked out the fibularis longus and brevis to see if it was tentative palpation. Neither the tendon nor the muscle was tentative palpation. HEP, we kept it same, kept it simple, trying to get more compliance. Don't want to complicate it anymore. Going to continue on the plan of care. It seemed to be working. The slow, gradual increase in range of motion besides the last week, but we understand it's been a week since her last visit, so we're expecting to continue to get slow increase and maintaining ranges of motion. Also need to continue to increase the intrinsic foot to provide strength for that lack of passive stability. And we're going to follow up after the weekend. Continue graded exposure to the foot intrinsic and extrinsics. Reassessed tibialis posterior and clear the lumbar spine next visit. So if anybody has any other suggestions, feel free to email me, let me know. Thank you very much.